Hello, everyone. I'm Krista Lentine from St. Louis University, and I'm honored to be here with Dr. Snyder to share a perspective on optimizing living donor follow-up in contemporary practice. We'd like to thank the organizers, including Deanna and Angel, for the opportunity to be part of this program. It's really wonderful to join you all for this informative conference, and we're learning a lot from the discussion. So these are my disclosures. And then here are Dr. Snyder's disclosures. And so today we'd like to talk with you about the state of living donor follow-up in this country. Living donor transplantation has been practiced for more than 60 years, with the first living donor giving a kidney to his twin brother in 1954. And this donor, Ronald Herrick, developed end-stage kidney disease at an advanced age, but reportedly was very satisfied with his donation decision. And it's notable that since that time, we still don't have a systematic approach to collecting long-term outcomes data on living donors. And importantly, the scope of living donation has expanded to include living liver donation and less commonly, donation of other organs. So there are some key reasons why the community needs to know the risks attributable to donation, including that donors must give informed consent, and so should be appropriately educated on what they are consenting to. The programs must ensure donor safety, and clinicians must work to mitigate risks and threats to safety. But again, to do that, risks must be understood. And because living donation is a procedure with lifelong implications, it necessitates long-term follow-up. The median age at donation is approximately 40 to 45 years, and general life expectancy for this age group is approximately 80 years. Events important to donors like kidney failure or end-stage organ failure are infrequent, and so can only be captured with long-term follow-up. But to date, long-term studies have fallen short of providing the data the community needs. And this is because many donors are lost to follow-up, that most studies have less than 10 years of follow-up, and that retrospective controls have been problematic. And if we were to apply star rating to available evidence, we'd conclude that there is good quality data on short-term outcomes, fair data on intermediate term outcomes, but limited data on long-term outcomes. And this is an example of follow-up data and missingness in a meta-analysis of post-donation hypertension studies. The size of the bubbles represents the number of donors in studies with each follow-up duration. And this illustrates a dominant contribution from studies with 7 years or less of follow-up, and missing data affecting all studies. So to understand the lifetime consequences of living donation, we need to overcome problems of loss to follow-up and inadequate comparator groups. And solutions might include improving resources through the Living Donor Collective, which Dr. Snyder will outline and will discuss in detail. But briefly, in the collective, we seek to offer solutions by starting registration with candidates. And this approach is designed to provide information on barriers to donation, capture controls, for example, individuals approved to donate but do not donate, such as for recipient reasons, and to capture long-term post-donation follow-up. So let's examine some ways to obtain long-term follow-up, starting with surveys. And the University of Minnesota has a well-characterized living donor cohort that they have examined in a number of studies. For example, in a 1992 publication, they reported on a cohort of 135 individuals who donated in 1963 to 1970. And of the 93% they could locate and contact for a postal survey, they achieved a response rate of 56%. This group has extended their work in a series of publications. For example, in one more recent study where the cohort had grown to more than 4,000 donors, they reported a 93% response rate. But what is really notable here is the amount of effort and cost it took to achieve this. The acknowledgements are extensive, illustrating that a very large team of staff, students, and extensive funding was needed to achieve this degree of follow-up. New methods for tracing individuals can be applied in the research context, like Accurate and LexisNexis. But even using these methods, response rates of 50% or less are not uncommon. ReLive is an NIH-funded study of donors at Minnesota, Mayo Rochester, and the University of Alabama. Again, a well-resourced study with NIH funding, but surveys achieved only about 36% response rates. In the modern era, the use of landlines for communication has clearly declined, as most people now communicate through devices such as smartphones. But this also raises the opportunity for communication via texting. And preliminary surveys of donor access to and interest in using smartphone applications related to follow-up demonstrated high rates of smartphone ownership and interest in engaging with apps for portions of follow-up. For example, in this particular survey, email and text messaging were the preferred communication modalities, but text received higher response rates, perhaps based on more real-time engagement. The study also demonstrates disparities with lower response rates in African Americans. So the concern for differential engagement always needs to be monitored with different strategies and tailoring applied to attempt to reach all donor groups. Follow-up may also be achieved by seeing donors in clinics, and this model has been reported on internationally, especially in systems with national health insurance. For example, Switzerland uses a model of living donor follow-up in primary care clinics with reporting back to a registry, and reports follow-up of approximately 65% at 10 years. And Norway uses a model of lifelong follow-up with the local nephrologist, where care is free of charge, and reports about 60 to 70% follow-up at 10 years. And these studies have set some benchmarks for what we might expect to obtain in the United States. We can also conduct linkages to other data sources. And we've conducted a series of studies over the past decade linking the National OPTN Registry to other information sources like medical billing claims and pharmacy claims. And this methodology has yielded some key findings, like recognition of racial variation in medical outcomes after living donation. But to date, there is no good information source capturing information upstream at candidate evaluation. So I did want to share that the AST Living Donor Community of Practice has formed a finance work group that was created in response to an initiative of a consensus conference. This group is chaired by Andrea Tietjen and includes some of your key leaders who are active at TMF, such as Gwen McNatt, Robert Howie, Ursula LeBron-Branks, and Linda Oler, along with some physicians and a coordinator. And we've been looking at barriers to follow-up as one project. For example, we recently examined SRTR data to look at associations of lack of insurance and other sociodemographic traits with deficiencies in OPTN mandated follow-up after living kidney donation. And we found the completion of OPTN follow-up, which is mandated at 6, 12, and 24 months, has improved in recent years, but is consistently lower for uninsured donors, indicating the importance of healthcare access in the US system. In multivariate regression, uninsured status was associated with 17% lower odds of 6-year clinical follow-up, and 14% lower odds of lab follow-up. And follow-up was also lower for living donors who were African American or Hispanic compared with white donors, unrelated to the recipient, not working, or had less than college education. And this analysis was just recently published by the American Journal of Kidney Diseases. We also conducted a survey of living donor kidney programs on managing the costs of OPTN mandated follow-up, and identified a number of practices, including some of which are not consistent with Medicare reimbursement manual, like billing follow-up to organ acquisition or the cost report, indicating a need for some education, but also explicit interest in more education and resources by program staff for managing follow-up costs. And so in this context and with this background and framing, we wanted to share about the SRTR Living Donor Collective, an effort to establish a lifelong registry for living donor follow-up, and have a conversation about your feedback and questions on this project. So now Dr. Snyder will describe the collective in detail. Thank you.
Thank you so much, Dr. Lentine, and it is really an honor to be invited to talk on this topic at the Transplant Management Forum, and my thanks as well to the organizers for giving Dr. Lentine and I a chance to talk with you about the importance of live donor follow-up, and to highlight the Living Donor Collective, which is an effort of the Scientific Registry of Transplant Recipients. Some background on the project: SRTR began to establish this Living Donor Registry to study access and long-term outcomes of living donation. This was established in the SRTR contract, with the pilot registry beginning in 2018. As part of the pilot, we were able to enroll 10 kidney programs and 6 liver programs. And the LDC data and collection process was established and refined during this pilot phase. We did begin to expand the registry in 2020, when HRSA called for an official expansion of living donor, the Living Donor Registry, to include all living donor candidates in the United States. And so the role of the program is essentially to build off of the research that Dr. Lentine has just shared with us, that there are challenges to long-term follow-up. I think the most important of which is the apples to apples comparison problem that Dr. Lentine highlighted. The Living Donor Collective is enrolling patients at the time that they were brought into the clinic for an evaluation to become living donors. And so what that allows us to do is to capture reasons that these patients do not go on to donate, if they do not go on to donate. And of course, if they do donate, we have that captured in the registry as well. This allows for us to construct a control group. Perhaps patients that were evaluated to be living donors but did not go on to become living donors, but they were medically cleared to be living donors. Perhaps a potential recipient had more than one family member, for example, and they were both cleared to donate, but ultimately one was chosen. The one that was not chosen perhaps makes a very good control subject, so that down the road, when we're able to assess long-term outcomes of these donors, we have a built-in comparator group of patients that were cleared medically to donate, but did not donate. So the SRTR's role in this is just that lifelong prospective donor follow-up, including those controls as well as the donors themselves. And we intend to leverage data linkages as best we can to study longer-term outcomes. So a bit more about the purpose and goals. We're trying to establish a better understanding of long-term risks for these live donors. And again, that control group is the key to really establishing a good comparison, because we know live donors are generally screened out to be very healthy individuals relative to the general population. We also have the ability within the registry to study access. What are the reasons that patients are being denied live donor opportunities after that initial evaluation? We are collecting in the registry the reasons that a patient may have been declined to go on to become live donors. And so this allows us to study what were the outcomes following those events as well, and to look at variation across programs that are participating to see if those reasons are commensurate across programs. We've already seen some interesting results from that, even as part of the pilot project itself. And then the registry will enable us to share best practices across the participating programs. We are creating reports that the programs can review periodically to see their enrollment within the program and the results and outcomes of the candidates for live donation that they've screened. To date, participation is voluntary. There is no funding provided by the collective, and we've been so thankful for the pilot sites and additional sites that have expressed interest in participating. We are in the process of examining all SRTR and OPTN living donor data collection. With the OPTN, the Living Donor Committee and the Data Advisory Committee have formed a living donor data work group where we're taking a holistic approach to what data are necessary, both for the OPTN's perspective as well as the Living Donor Collective's perspective for assessing long-term outcomes of live donation. And so we certainly are hoping to find ways to align those collection efforts as best as possible. And that effort is ongoing, and we're very thankful for the support of the OPTN and those on those committees for their assistance in that effort. Again, the design of the program is that we are including all donor candidates that are evaluated at the programs, both those that go on to donate and those that do not. The transplant programs themselves are submitting registration data for the candidates at the time of that evaluation. They then will provide to the registry the reasons that the candidates do not donate. And then from essentially that point forward, the SRTR is taking over the long-term follow-up. The registry exists to establish a cohort of patients that will allow us to link the data set to other sources of data to establish things like deaths or end-stage kidney disease events or other events that we can identify from other data sources. But also the project will allow us to provide targeted surveys to the patients enrolled in the program. So if there are specific surveys that researchers would like to address in live donation, the registry in the future will be a good resource for that. There will be avenues to partner with external researchers as well. And so we look forward to the day when we've got a robust sample of donors and donor candidates within the system that will now allow those types of surveys to go forward. A bit about the data collection process. Again, we're trying to minimize effort for the transplant programs, and we're trying to establish ways that we can leverage electronic data transfer as best as possible. The current effort for the programs themselves are essentially two forms: the initial registration form that is submitted as the patients come in for their initial evaluation. This is a similar form to the OPTN's living donor registration form, but of course not identical, because this is not a form that's supplied at the time of the donation. This is supplied at the time of the initial evaluation of the donor candidate. And so there are some overlapping elements, but it's a distinct different form collected at a different point in time. And then we have what we're calling a donation decision form, which is also submitted by the transplant program, indicating whether the donation occurred, and if not, the reason for not donating. This is generally due approximately 6 months after the evaluation for liver and 2 years after kidney. Certainly programs can enter that form whenever they're ready. Those 6-month and 2-year forms are the point where the Living Donor Collective actually will prod the program and ask about if that evaluation has gone forward or not. And the program will then submit the donation decision form. And then SRTR has begun a 1-year follow-up process at this point, just to establish initial contact with the candidates that are registered in the system. We are not collecting clinical data at this time, so we're not trying to achieve a system that captures serum creatinine or bilirubin in the liver donors. And that is happening at the 1-year mark, either after the decision not to donate or the donation itself. And this schematic essentially illustrates the same concept. Those left two boxes are the boxes that are collected by the transplant program and transferred into the LDC system. We can then pair that up with data collected by the OPTN itself. For example, the live donor registration form as well. to do some cross-checking across those at this stage. And then the follow-up data, the long-term follow-up is really being conducted by the SRTR with candidate and donor long-term follow-up, and again, data linkages and surveys. All of this in total encompasses what we're calling our LDC database. So this initial one-year emailed survey has gone out just to establish some initial contact. There's a number of questions we've asked just about how their health is in general, and just trying to achieve this system, start to initiate this system of regular contact with the participants in the registry. And to date, this is what we've received back. We've had about a 41% response rate overall. And the interesting part about this is perhaps not a surprise, but when we split that out by whether the person actually became a live donor or not, there's a pretty distinct split between those that are willing to give us a response. This is something we're hoping to improve upon. We have a 52% response rate for those that became donors, and you can see the ends there associated with that. And we have only a 26% response rate at the time the survey went out for those that did not go on to donate. So clearly the ones that actually did donate have a more of a vested interest in participation. But we as a staff are reminded that there are other ways that we can do those targeted data linkages to find those outcomes in these participating patients within the program, both the donors and the non-donors. And so while the surveys might be one aspect that we can reach out and try to study some important outcomes in the live donors, that is not our only method of follow-up in these patients. So we're certainly going to be studying ways that we can engage these participants, particularly those that do not go on to donate, to try to raise that response rate for future surveys as well. And I will turn it back to Dr. Lentine. Thank you.
All right. Well, thank you, Dr. Snyder. So as we work to transition the Living Donor Collective from a pilot to a national registry, we wanted to understand factors that may be barriers and facilitators to program participation. So to do this, we conducted an electronic survey of U.S. living donor programs this past fall, 2021. And the survey was distributed via email and listserv postings, and respondents were asked to rate 9 considerations related to Living Donor Collective participation, and also given the opportunity for free text responses. We received 132 survey responses, and there was at least one response from 87 living donor programs, including 46 kidney programs, 33 kidney and liver programs, and 8 liver program alone staff. And kidney program respondents represented 40% of living kidney donor recovery programs and 52% of living kidney donation procedure volume. Liver program respondents represented 54% of living liver donor recovery programs and 70% of living liver donation volume. So responses are shown here for individual respondents in light blue, and then at the program level, where we applied a selection algorithm as in prior surveys to obtain one representative response per center. Overall, 86% of program representatives strongly agreed that funding adequate to cover the cost of data collection and data entry for candidate registration would facilitate Living Donor Collective participation, while only 2% disagreed or strongly disagreed. 92% of program respondents agreed or strongly agreed that having options to submit registration data electronically would enable participation, while 74% reported that elimination of requirements to submit preoperative donor candidate demographic and clinical information to the OPTN when their program submits those data to the collective would be helpful. 22% were neutral on this topic, and 4% disagreed or strongly disagreed. Reduction in the duration of post-donation OPTN required follow-up data collection to compensate for effort spent registering candidates in the collective was anticipated to enable LDC participation by 59%, while 23% felt neutral and 17% disagreed or strongly disagreed that such a change would facilitate their participation in the collective. 86% of respondents strongly endorsed or endorsed assurance that submitted data remain private and not be used for regulatory or insurance contracting purposes as motivation to participate. And nearly all, 91%, identified assurance that participation in the collective will not preclude their program's ability to collect living donor follow-up data for research or clinical purposes as enabling to participation. Assurance that the LDC will not require programs to provide additional donor contact information in the years after donation was rated as enabling by 84%. And finally, 88% felt the ability to obtain data from the LDC on the program's donors during follow-up would motivate participation. And 83% were motivated by ability to obtain and use de-identified data on LDC participants for research projects. Free text comments emphasize the importance of funding and support for staff effort, electronic data submission and ease of use, data security, data access and collaboration, and included expressions of support and interest. So based on this survey, some possible strategies to support living donor collective participation might include funding adequate to cover the effort of data entry. Of note, the collective does provide a small amount of support for information technology setup, but otherwise doesn't come with specific funding. However, we're working with the OPTN to discuss streamlining and harmonizing the overall amount of data entry required for living donors across the platforms. And there are conversations on whether the effort of registration could be charged to organ acquisition, perhaps if used for programmatic feedback and quality improvement. And this is a topic of ongoing discussion. Electronic data submission to reduce burden is a priority. And there are badge upload templates that exist. We are also building extractions and uploads for donor intake systems like Breeze and the NKR Dash screening tools. And at individual centers like mine, we've been working on supplemental EPIC and EHR extractions that may help for field-defined information like blood pressure in labs. Avoidance of duplication of effort with OPTN data entry is a key concern. And of note, an OPTN living donor data work group has been formed to review all living donor data collection. And there is an interest in access to program and aggregate data, and this is the plan and commitment. And note that an OPTN living donor data work group has been formed, whose goal is to develop recommendations for the future of long-term living donor data collection and ideally to harmonize and streamline these two data collection efforts. For folks interested in details, we have several publications out on the Living Donor Collective pilot experience, including a new annual data report published in the American Journal of Transplantation in March of 2022. We're very interested in honoring collective participants in building a community. We've recently launched a badge that participating centers can post on their websites. And participating centers are also designated with an icon on the SRTR website. There's a great team at the SRTR supporting the collective. Dr. Bert Kosiski is my co-medical director, who's well known to the field. And we have administrative expertise from Kaylin Neidstedt, community engagement support from Tanya Eberhardt and Mona Shater, and analysis Yoon An and Patrick Johnson. And we're adding a new project coordinator that we'll introduce to the community very soon. So thank you again. We're very interested in your feedback and experiences and questions. So if you do have any questions after using this electronically, please do feel free to reach out. And I did want to thank my transplant team, some of whom were here at TMF, and they've been very valuable supporters of the program's participation in the collective, and to all the programs contributing to date. So thank you very much for your attention, and we look forward to ongoing discussion.
I will add my thanks. Thank you for your interest in live donor follow-up. And if you do want to reach out, in addition to the ways that Dr. Lentine highlights on the screen here, feel free to email the SRTR at our general information line, srtr@srtr.org, and we would be happy to get you more information about the effort. Thank you very much.